To begin by thanking Dr. Sumit Gujral and Dr. Anita Borges for this opportunity to speak on the screening tests in coagulation lab on a case-based approach. I have to really give them a big thank you, because they've taken us through so many important classes through this COVID pandemic when things look very bleak and difficult for the students. And it also gave all of us an opportunity to hear some really good speakers on this platform. So the overview of this talk will be that I will try and recapitulate the coagulation cascade. Then I will discuss the tests included in the coagulation screen and their utility and their drawbacks. We'll look at the mixing studies for coagulation factor deficiencies and inhibitors. We'll see a couple of illustrative cases and then have a look at an algorithm for screening for bleeding disorders. So if we look at the in vivo hemostasis, the purpose of hemostasis is to ensure that if there is an injury to the blood vessel, the organism does not exsanguinate. That means the blood flow has to be maintained in such a way so that the circulation remains intact. So for this, the first thing that happens is, if you look in the upper panel, as soon as there's an injury and a break in the endothelium, there is a signal to the endothelial cell to produce endothelin, and this causes a reflex vasoconstriction. So this mechanical method helps to decrease the blood flow through that and to narrow the area of efflux of blood from the blood vessel. The next thing that happens is that the platelets have to be brought into the picture so that they can plug the gap. Now for this, if you look at the second panel on the left, there is this is the subendothelium, which is now exposed, and this contains collagen. Von Willebrand factor is a plasma coagulation protein which is circulating in the blood. As soon as it comes in contact with the subendothelial collagen, this von Willebrand factor, which is circulating in a tight bound form, opens up. And with that, a domain is exposed with which it attaches itself to this exposed collagen. So now the von Willebrand factor is adhering to the collagen. This von Willebrand factor has to perform a very important function of bringing the platelets and fixing them to the site of injury. So it acts like a bridge between the collagen and the platelet. It recognizes the platelet through the GP1B receptor, and once the platelet is fixed with there is a signal to the platelet and it gets activated, and it exposes more receptors on the surface, the GP2B3A receptor, and via this receptor, adjacent platelets can now be linked by the fibrinogen molecule. So where there was one platelet, now there can be multiple platelets linked by fibrinogen. The whole aim of this exercise is to convert the soluble plasma protein fibrinogen into fibrin. And fibrin will act like a cement, which will bind down the platelets to the site of injury at the endothelial surface. So now, thanks to this primary hemostasis, which involves the blood vessel and the platelets and the von Willebrand factor, the platelets and fibrinogen are now fixed to the endothelium. If you look at the panel on the right side, as soon as there's an injury, tissue factor is exposed on the endothelial surface. This tissue factor now triggers off the process of getting the other coagulation proteins to get themselves to fix on to this platelet surface. All this is a very nicely, tightly regulated process so that the clotting mechanism is maximally activated at the site of injury and does not become a diffuse process. So a number of coagulation proteins are involved in the process of forming a fibrin clot. And as I've already discussed, the most important part is the generation of thrombin, which will convert fibrinogen, which is soluble, into insoluble fibrin. And this fibrin is then supposed to link up with other fibrin molecules and form a fibrin polymer, which you can see at the bottom panel. And this fibrin polymer will become tight and will prevent any further leakage of blood from there. So how does thrombin come into the picture? A little bit of thrombin is always present in circulation, as if the system is ready to get into action at any time. But most of it is generated by the action of tissue factor. You look at the panel on the right side. This tissue factor combines with factor 7, which is present in the circulation, but at a surface which provides phospholipids. So in the body, this would be the platelet surface or the endothelial surface. And this binding leads to the activation of factor 7 to factor 7A. And this complex, the 7A tissue factor complex, now converts factor 10 into factor 10A. So this is a 10A's activity. This is, however, a very small part of it all. The major effect is by the action of the 7A tissue factor complex to activate factor 9 to 9A. And both of these, 9A and the 7A tissue factor complex, now act to convert factor 10 to 10A, which in the presence of factor 5A and phospholipid and calcium converts prothrombin to thrombin. And thrombin, as we know, will convert fibrinogen to fibrin. So we can see the 7A tissue factor complex is important and the 9A complex is important. As soon as thrombin is generated, it amplifies the whole coagulation reaction by increasing the amount of factor 5A activation, by increasing the amount of factor 8 activation, and by activating factor 11. So the extrinsic pathway, so-called, the intrinsic pathway, so-called, and the common pathway, so-called, all are now in action just to convert fibrinogen into fibrin. So How do now we can make out that this is going to be a very complex exercise, so many proteins doing so many things. To understand this in the laboratory, we have separated them artificially into two pathways, the intrinsic, the extrinsic, and the third pathway is the common pathway, which ends in fibrin polymer formation. So the PT test addresses the extrinsic pathway, which means it looks at the formation of the factor 7A tissue factor complex and till the formation of the fibrin polymer, because that is how our instrument will see the clot, or it can sense a mechanical clot. The APTT, on the other hand, addresses every other clotting factor except factor 7. So 12, 11, 9, 8, all these, if there is any defect or a decrease in amount, it will cause a prolongation in the APTT. Any defect in the common pathway will also cause a prolongation of the APTT. The TT has a very small role. It just looks at the conversion of fibrinogen into fibrin monomers. So if there is a problem in the fibrinogen molecule, this will be brought out very well by the TT test. So what is the use of a screening test, or when will we be required to put these into play? Usually the lab will have to answer to a clinical query when there is a patient who has come with bleeding and we don't know the cause, or if there is a family history of bleeding and we are investigating the other family members, or if a surgical procedure is being planned and the surgeon wants a bloodless or a clean field and wants to make sure that there will be no bleeding. So then we need to exclude a bleeding disorder. And incidentally, if somebody is found to have an abnormal test, then we may need to do one or more screening tests to find out what is wrong. So because clotting is such a complex interplay of blood vessels, platelets, plasma proteins, it's very easy to understand that there will not be one test which will answer all our questions. So for this, a battery of 6 tests usually forms the clotting screen. This includes the platelet count, the prothrombin time, the activated partial thromboplastin time, the fibrinogen assay, the thrombin time, and the bleeding time. Out of these, the last two are usually done a little less than the upper four which are shown in the panel. Thrombin time essentially will help in fibrinogen disorders, and bleeding time has some issues, so it's not remained a very popular test and has been replaced by the platelet function analyzer in some places. Before we start going into the coagulation screen test, it's important to remember that these tests are difficult to do. They are expensive to perform, and they're very finicky to pre-analytical handling of the sample. How the sample was collected, what was the situation, how was it transported, how was it centrifuged, all that affects the results. So it's very important before we start testing to get some background information. It's good to know that what is the number and nature of bleeds. There is likely to be an underlying bleeding disorder if there have been multiple bleeds and if there are bleeds from multiple sites. If they are deep bleeds like hemarthrosis and muscle hematomas, then we are probably thinking of a coagulation factor deficiency. But if they are mucocutaneous bleeds and like petechia and skin bleeds, then probably there may be a platelet-related defect. This is important initially so that we can decide the further course of testing that we need to undertake. We must always have history of a comorbid illness. Most clotting factors are synthesized by the liver, so in any liver disease, there may be a decrease in the clotting factors and a prolongation of the clotting times. So this we must be aware of. This may mask an underlying bleeding disorder sometimes. In DIC, the other thing happens, most of the clotting factors are consumed, so they may be decreased. So we must know that what are we trying to investigate in which background. We also need to know if the patient has received any recent transfusion, because then we will not get his baseline levels of clotting factor, and the clotting times may not be so prolonged. So the screening tests may not be sufficiently prolonged to give us the warning that there is a bleeding disorder. But this is not always possible. Many times the patient is already transfused when we get a request. So in that situation, what I have found helpful is to ask if there is another family member who has the same illness. And if he's available, then it's easier to test on him and get a better idea of what actually is wrong. We need a freshly drawn citrate sample for coagulation tests, and samples which have been stored overnight in fridges, etc., are not really preferred because they may activate certain factors, and some of the labile factors and short-lived factors may decrease over time. So it's good to have a freshly drawn citrate sample if we are looking for a bleeding disorder. There must be no clots in the sample before transfer to the lab, because this will consume some of the clotting factors and hence cause an abnormal prolongation or shortening of the clotting times. In our lab, we usually take the help of a pathologist who takes good history and decides which sample is required and when we should ask for the sample, so that we avoid all misleading testing. And I personally have found it very helpful to maintain a register of all bleeding disorder patients in my lab, because many times in poor patients, they may have lost their records, and when they come with a bleeding problem, it's difficult to work them up from scratch. So just looking at the register tells us that yes, this is a patient of hemophilia. We don't need to do the screen again. So starting with the first test, this is the bleeding time. It's usually done by the IV method. This is a test of primary hemostasis, so it assesses the platelet plug formation and capillary integrity. So the BP cuff is inflated over the forearm to occlude the venous supply. After that, using a template which has a lancet of a fixed depth, which will go to a fixed depth and make an incision of a fixed width. 2 such incisions are made on the forearm, and as soon as the bleeding starts, with the help of a filter paper and using a stop clock, the sides of the wound are swabbed every 15 seconds till the bleeding completely stops. It's important to not disturb the clot, and after that we can see by the number of spots we have as to how many seconds have elapsed or how many minutes have elapsed. Normally the bleeding time is between 1 and 5 minutes. If there is a platelet function defect, or if there is a severe bleeding disorder, or there is a drug intake, then the bleeding time may be prolonged. The biggest problem of this test is it needs a very skilled operator, and it's not very sensitive to mild bleeding disorders. It tends to leave a scar. And when you're trying to look for a bleeding disorder in a child, they usually struggle. So it's very difficult to perform this test well. And many times this test is performed to assess the bleeding risk at surgery where it really has no meaning. So most people don't do the bleeding time currently. So with this, I come to the first poll question. Bleeding time is likely to be prolonged in which of the following clinical conditions? Hemophilia A, hemophilia B, hypocalcemia, or Glanzmann's thrombasthenia. Please put your answers there, and the host will then let me know what you have polled. Yes, Lopa, do we have the results?
Almost 98% of the people have answered option 4.
So that's absolutely correct. You're very right. Bleeding time is looking at primary hemostasis. So we are looking at the platelet and we are looking at the blood vessel. The others are clotting factor deficiencies, and hypocalcemia, of course, is just a red herring that I've thrown in. So it is indeed Glanzmann's thrombasthenia where I expect a prolonged bleeding time. So there is a point of care instrument now available called the Platelet Function Analyzer 100, which can be used for assessing bleeding time by the bedside. And in this machine, we take a saturated blood sample and put it into the machine, which has a cartridge. This cartridge is coated with a membrane made of collagen, and the membrane collagen is coated by another layer of either ADP or epinephrine. The blood from the test tube is sucked in at high shear force, and so the platelets, the red cells, everything will move towards the aperture which is there in this membrane. As soon as the platelets come in touch with collagen, like they do in the body, they will start adhering. And once they get activated by the epinephrine and the ADP, they will start aggregating as well. So these platelets will gradually go and occlude this opening, and this is called the closure time. If there is a bleeding defect, this closure time will be prolonged. And even with the drug therapy, say for instance aspirin, the closure time may be prolonged. The problem with this test is it looks very easy to do and all, but it's expensive, and it is also insensitive to mild disorders. And because it takes the whole blood, it is affected by the hematocrit and platelet count. So coming next to the first test, which is the prothrombin time. This is the time taken for plasma to clot upon addition of calcium and thromboplastin. So now thromboplastin is the tissue factor which we saw in, which is present normally in the blood, in the vessel wall. Here we'll have to add it from outside, and we'll also have to add phospholipid. This test measures the integrity of the extrinsic system and the common pathway. So it is the prothrombin time is therefore dependent on the levels of factor 7 and the common pathway 2, 5, and 10 in the plasma. So this is what we are looking at, the extrinsic pathway. We look at this part of the coagulation cascade. When do we usually need a prothrombin time? When we are monitoring vitamin K antagonist therapy, such as warfarin and acetone. In patients who have bleeding, such as DIC and liver disease, these are far more common indications than screening for a bleeding disorder, which is usually less common in amongst all of us. Liver disease and vitamin K therapy are far more common indications, and in individuals who have a family history of bleeding. So in the procedure of the test, we incubate that sample in a water bath at 37 degrees for 10 minutes. We need to do all tests at 37 because most of the coagulation factors are enzymes, so they act best at that temperature. Because when we collected the sample, we used a chelating agent to remove calcium. Now we have to put the calcium back because we know calcium is required for the clotting reactions. We start the stop clock, and we take the tube out every three times every 5 seconds and see when the clot is formed, which is when the plasma stops moving. The test is done in duplicate, and we must always do a control sample as well. How do we report the test? The PT is reported either in seconds. A normal reference range depends on the kind of thromboplastin we are using. It usually sits between 11 and 16 seconds or 10 and 12 seconds. We can use the information that we get from the PT test for finding out the INR. Now, the INR is the international normalized ratio, which is the ratio of the patient's PT with the log mean normal PT raised to ISI. Log mean normal PT is the geometric mean of our normal pool plasma, and ISI is a value which measures the sensitivity of a particular thromboplastin reagent versus a reference standard. Normally, the INR should lie between 2 and 3 if the patient is taking an adequate dose. If it goes beyond 3, there's a danger of bleeding. If it's less than 2, then there is a danger of thrombosis. We can also calculate the prothrombin index, which is a ratio of the normal PT to the patient's PT. And this comes in help when we have to do intra-abdominal FNACs and procedures like that, where to maintain hemostasis, we would need values above 80%. The PT ratio is exactly the reverse, and this can also be used in some settings. Now, the PT reagents, if we want to use a PT reagent for INR, we should use an ISI, which is as close to 1 as possible. The thromboplastin of human origin is the best, though you can get it from rabbit or sheep brain. And recombinant tissue factor is the best because it is safe from any animal protein, and the ISI is usually very close to 1. This reagent must always have a sensitivity to a factor deficiency of at least 30%. Because when we are screening for a bleeding disorder, we are looking for factor levels which are low. So our PT must be prolonged if the factor deficiency is less than 30%. We should not be getting a normal PT at that. So we should choose a reagent which has a good sensitivity. The commonly used PT reagents are more sensitive to factor 7 and 10 deficiency as compared to deficiencies of factor 2, 5, and fibrinogen. The PT reagent contains a heparin neutralizer. So in heparin therapy, we get APTT prolongation, but not usually PT prolongation. And it also contains a large amount of phospholipid, so patients with lupus anticoagulant may never show PT prolongation. The derivation of ISI, we must remember, is based on patients receiving warfarin. But the current practice these days is to use INR for predicting bleeding tendency in patients with other indications, such as liver failure and DIC. This is not really a very good practice because it was standardized for patients receiving warfarin and may be misleading in this situation. A prolonged PT can be seen with administration of oral anticoagulants, the presence of inhibitors, with vitamin K deficiency, in liver disease, particularly obstructive jaundice, disseminated intravascular coagulation, and one of the factor deficiencies of 7, 10, 5, or 2. Sometimes the PT may be shortened. This usually happens if you've got an activation of the sample, or in the setting of a chronic TIC, or if the sample was frozen because factor 7 gets activated, or if there has been recombinant factor 7A therapy. Now coming to the APTT, this is called activated partial thromboplastin time. Partial it is because it contains no tissue factor. So now how do we start the clotting reaction? We will need an activator. So there is no tissue factor now. So for that, those activators are kaolin, psilite, silica, or ellagic acid, and various reagents may contain different amounts and different forms of these activators. So this is the part of the coagulation cascade that the APTT addresses. That means it's essentially all other factors other than factor 7. It measures the clotting time of plasma after activation of the contact factors, this part, in the presence of phospholipid and calcium, but without thromboplastin. So it indicates the efficiency of the intrinsic pathway. The three main uses of APTT are essentially to detect a factor deficiency of any factor other than factor 7, to monitor heparin, especially unfractionated heparin, and for lupus anticoagulant detection. In the procedure of the test, the sample has to be activated first because there is no, remember, there's no tissue factor. So the activator is added, and this is then allowed to activate the sample for a fixed time, 3 or 10 minutes. Then we add phospholipid and calcium, start the stopwatch, and again, keep tilting the tube and checking when the clot forms. The clotting time for APTT is usually between 25 to 32 seconds, but maybe even longer depending on the reagent. And the common causes for an APTT prolongation are DIC, liver disease, contamination with heparin or therapy with heparin, and sometimes presence of some inhibitors like lupus anticoagulant, or the presence of a direct acting oral anticoagulant, or deficiency of any other coagulation factor other than factor 7. A shortening of the APTT will be seen if there are very high fibrinogen levels and high factor VIII levels. These are both acute phase reactants. So in acute situations, these may be actually the APTT may get shortened. The APTT reagents also differ from each other in the type of activator that they contain and the type of phospholipid that they contain, because these are the essential two things that the reagent contains. If you decrease the phospholipid, it becomes very sensitive to lupus anticoagulant, and different activators have different sensitivities to factor deficiencies. So it's not that my lab is finding a factor deficiency, your lab will also find the same degree of factor deficiency if we are using different APTT reagents. For routine screening, it is better to not use a very sensitive APTT reagent, since what we will find is that then the APTT will be prolonged even when there is a minor fall in the coagulation factor levels. I would like to look for a bleeding disorder where there is a significant decrease in the clotting factor, say 30% or less. I do not want to look at a prolonged APTT in a person who has a clotting factor of 47, because he's not likely to bleed because of that. His clotting time may be abnormal, but he may not bleed. But in the lab, I might need to do more and more tests to find out why this APTT is prolonged. So we don't recommend using a very sensitive APTT reagent if you're doing routine work. And for heparin, we should use some reagents which will be sensitive to heparin. So that brings me to my second poll question. When selecting a reagent for APTT testing, which of the following considerations is correct? The reagent must have a low phospholipid content. It must be sensitive to deficiencies of all factors of the intrinsic pathway, must have a sensitivity of at least 30% of a coagulation factor of the intrinsic pathway, or must have a sensitivity of at least 50% of a coagulation factor of the intrinsic pathway. Please poll. I'm happy that that statement has gone correct. The reagent must have a low phospholipid content. Yes, it must be. If you have a low phospholipid content, it becomes very sensitive, so it will give us a problem there. Should be sensitive to all deficiencies of all factors of the intrinsic pathway. Not really what we want, because we do not want to detect a factor 12 deficiency which doesn't cause a bleeding disorder. It causes a APTT prolongation, but not a bleeding disorder. So we don't need it to be sensitive to everything. And if it is sensitive, or if it gets prolonged only if there's a 50% factor deficiency, then it is not good, because it will miss a number of our patients with bleeding disorders. Coming to the fibrinogen assay, this is the most abundant protein, coagulation protein in the plasma, and has very high levels. It can be measured by a clot-based, immunological, or a physical method, but most of us prefer a functional or a clot-based method, the Klaus method. And this is the part of the clotting cascade, what we look at when we are looking at the fibrinogen assay, the conversion of soluble fibrinogen to fibrin. And what we do here is that the plasma sample is diluted with a buffer so that any inhibitors which are present in the plasma can be removed out. Then we add a strong thrombin solution, which will convert the fibrinogen to fibrin, and we measure the time till the clot is formed. And how much fibrinogen is there, we can read off from a calibration curve where different concentrations of fibrinogen have been plotted against the clotting time. Low fibrinogen levels will be seen in DIC, liver disease, thrombolysis, massive transfusion, and in afibrinogenemia, dysfibrinogenemia. Whereas high fibrinogen levels will be seen as an acute phase reaction, and they increase with age. So let me take you to case 2. There is a female child was brought to our hospital with history of bleeding from the umbilical stump on day 3. There was a history of an elder sibling death in the family with bleeding, but the cause could not be worked up. There were 2 other sibs who were alive and healthy, and she was being investigated in a nursing home where the clotting test revealed a prolonged PT and APTT. So very obviously the neonatologist over there gave injection with vitamin K, but there was no improvement. So a bleeding disorder was suspected, and she was sent to our institute. Here again, the pediatrician's first thing they did was to give a vitamin K injection just to make sure that that was not the reason, and then they sent the sample to us for investigations. So what we saw is that the PT was markedly prolonged, almost unclottable, and the APTT was also abnormal. It was unclottable. So the next thing to do would be the fibrinogen assay. And in this case, the fibrinogen was markedly reduced. We repeated this test after a month, and again, it was very low. So what we are looking at is a patient with afibrinogenemia who was bleeding from an unusual site. The other causes where PT and APTT can be prolonged are vitamin K deficiency, liver disease, DIC, deficiency of the common pathway factors, and a combined factor 5 and 8 deficiency. Now, why I have just mentioned this case here is mostly when screening tests are done, we try to save time, money, and precious sample by saying just do PT, APTT. But if we miss out the fibrinogen, then we might be actually delaying the diagnosis and sometimes be given even unnecessary therapy, as happened in this case. So it's good to do a fibrinogen assay if you're working up a bleeding disorder. Coming to thrombin time, now this is quite like our fibrinogen assay, except that here we use a weak thrombin solution, and we add it to the plasma and look at the time to clot. This is affected by the concentration of fibrinogen and the inhibitory substances like FTPs and heparin, which are present in the plasma. Normal range is between 15 and 19 seconds. So if it's prolonged 2 seconds beyond the upper limit, it's abnormal. And we usually use this test to detect heparin contamination in the sample, but it is very useful also in picking up afibrinogenemias and dysfibrinogenemias, and may also be prolonged in paraproteinemias and hypoalbuminemia. The thrombin time, just like the fibrinogen assay, looks at the same step, conversion of fibrinogen to fibrin. So this brings me to my third poll question. Which of the following conditions is not needed to perform a manual thrombin time? Calcium, thrombin, 37 degrees centigrade temperature, and the stopwatch. So these are very simple poll questions, but it'll help me to see that you're looking at the diagrams carefully. Yes, can we have the poll results?
All the people have answered as number 1, calcium, ma'am.
My God, I don't know why I'm even doing this class. Everybody knows all the right answers. Yes, absolutely correct. So it is a thought in our heads that all clotting reactions need calcium, but once thrombin is formed, then no calcium is required. So that's true. We don't need calcium in this reaction. Okay, a 5-year-old male was brought to the hospital with history of bluish patches on the arms and legs on minor trauma. He had joint swellings, especially in the right knee, since 2 years of age. And when we ran a clotting screen, we saw that the APTT was prolonged, PT, fibrinogen, and platelet count were normal. So my poll question 4 is, what do you think could be a likely deficiency in this situation? Does this patient have a factor 7 deficiency? Does he have a fibrinogen deficiency? Does he have a 8 deficiency? Or does he have a 13 deficiency? Yes?
All the attendees have answered the option 3, factor 8 deficiency, ma'am.
Absolutely right. So we know factor 7 deficiency would have caused a isolated prolongation of the PT, which is not there. Fibrinogen deficiency should have been caught by the fibrinogen assay, and factor 13 deficiency usually does not cause a prolongation of any of these clotting times, so it's unlikely to be that. So if we get a prolonged clotting time, the next thing we need to answer is that, is this prolongation because of a factor deficiency, or is it due to the presence of an inhibitor? And to answer this question, we perform a mixing test. So we see that the clotting time of PT, APTT, or TT is prolonged, any one of them is prolonged. What we would do is we would make a mixture of 1:1 of the patient's plasma with normal plasma. And then we repeat the same prolonged test on the mixture and record the clotting time. So what we are presuming is that if the patient's sample is deficient in one of the clotting factors, normal pooled plasma has almost 100% of all the clotting factors. So if we make a 1:1 mixture of these, we should get a normal clotting time back again. So say, for instance, in this example, if the APTT is 75 of the patient and the normal pooled plasma APTT is 25, and we make a mixture and we do the APTT again after that, and the APTT is 30 seconds, we call this a correction, because from 75 seconds, it's now come to 30 seconds, which lies in the reference range of 25 to 32. So this is suggestive of a factor deficiency. Whatever was deficient in this plasma has been replaced by this normal pooled plasma. So if the clotting time corrects, this indicates a factor deficiency. For deficiencies of the intrinsic pathway, that is factor 8, 9, and 11, we use the correction based on APTT, or the mixing test based on APTT. We can also use it for the common pathways, because we know that deficiencies of this common pathway will also cause prolongation of APTT. For the deficiencies of factor 7 or common pathway, we can use the PT mixing test. Just suppose, however, if the mixture shows an APTT of 75 seconds, so this has not corrected. It started with 75 and it is at 75, which means that whatever we added from here has not been able to correct any deficiency. Instead, something is there here which has inhibited this clotting factor from normalizing the clotting time. So this is suggestive of an inhibitor. The common inhibitors are lupus anticoagulant, heparin, which is iatrogenic, then factor 8 inhibitor, which may be seen in patients with hemophilia who have received replacement therapy, or even de novo in some elderly patients or pregnant females. And there may be inhibitors to any of the clotting factors rarely, and even the high levels of D-dimer and FTP may act as inhibitors. So when do we say that a clotting mixture has corrected? This is a difficult question to answer, because it varies from lab to lab, and there are many different ways of doing it. So the old method, when I was a student, we learned that what we should do is measure the APTT of the patient and of the normal pooled plasma, add these two and divide by 2. So 75, in this example, 75 of the patient, 25 of the normal pooled plasma, we add these two, it becomes 100, divide by 2 is 50. If the APTT of the mixture goes below 50, that means it's a factor deficiency and there is a correction. But if it doesn't go below 50, then it is an inhibitor, and we say that this sample is not corrected. So in this example, if it was 30, it's corrected, and factor deficiency, if it's 73, it's not corrected and an inhibitor. Another way of doing it is by calculating the Rossner index, which is the difference between the APTT of the mixture minus that of normal pooled plasma divided by that of patient plasma into 100. So in this example which I've shown you, if we take the APTT of the mixture, that is 30, minus that of the normal pooled plasma, which is 25, divided by patient plasma, it becomes 5 by 75, and this is 6. So if the Rossner index is less than 10, this indicates a factor deficiency. On the other hand, if this Rossner index comes to be more than 15, it indicates an inhibitor. So we can see there's a gap between 10 and 15. This is inconclusive. We don't know whether it is truly a factor deficiency or an inhibitor. In this situation, we may need to repeat from a fresh sample. The third way of doing it is by looking at the clotting time of the mixture. If the APTT of the mix is within 5 seconds of that of normal pooled plasma, we can say that it's corrected and there is a factor deficiency. So in the sample, the mixture is 5 seconds above the normal pooled plasma. We can say this is a factor deficiency, but here it's more than 5 seconds, so this is not corrected and it's an inhibitor. So once we have APTT which shows us correction, then we need to see which one of the factor deficiencies could be present, which is causing the prolongation and gets corrected on addition of normal pooled plasma. So for this, we can use a very good technique, which is if the patient sample is deficient in factor 8 and we mix it with a factor 8 deficient plasma, then obviously there is no factor 8 in the sample, so the APTT will not correct. If there is a factor 9 deficiency in the sample and we add factor 9 deficient plasma, again the APTT will not correct. So in this example, suppose to the patient's plasma we add factor 8 deficient plasma and we see that the APTT is not correcting, but it corrects with 9 and 11 deficient plasma, then we say that this is a factor 8 deficiency. If it is not corrected with factor 9 deficient plasma, that means this sample does not contain factor 9 and the deficient plasma also has no 9, so this is likely to be a factor 9 deficiency. And if it doesn't correct with 11 deficient plasma, then it is likely to be a factor 11 deficient plasma. So factor 11 deficiency. So a very easy way of finding out which factor may be deficient before we actually do a factor assay. Some people do not do this step and go directly to the factor assays, which is equally good. So once we get this always has to be confirmed by a specific factor assay. So now if you look at the example that we've seen, the patient's plasma is prolonged, APTT is 89, the normal pooled plasma is 38, the mix is showing correction, it's coming to normal, so it's a factor deficiency. When we add factor 8 deficient plasma, it's not correcting, but with factor 9 deficient plasma, it is correcting to what we expect. So this is likely to be a factor 8 deficiency, which we confirm by a factor 8 assay. So that gets me to my poll question number 5. In a case with an isolated APTT prolongation, in the mixing study with APTT, if there is correction with factor 8, factor 9, and factor 11 deficient plasma, then what is the most likely possibility? Is it a factor 7 deficiency? That means totally unrelated to the APTT. Is it a factor 12 deficiency? Is it a factor 13 deficiency? Or is it something totally unrelated, a platelet function defect? Please poll. Yes, Lopa?
30 have answered option 2, factor 12 deficiency.
Indeed, that's the right answer, because remember, we have not used factor 12 deficient plasma to do this test. So, and I haven't told you whether the patient was bleeding or not. This is just a sample we received in the lab, which has an isolated APTT prolongation. So that indeed, in factor 7 deficiency, I don't expect APTT to be prolonged at all. In factor 13 deficiency and platelet function defects also, I won't expect the APTT to be prolonged at all. So the only option here is a factor 12 deficiency. Now let's look at the other use of the mixing study, which is to screen for inhibitors. A 14-year-old male who had hemophilia A and was on monthly factor transfusions reported to the hospital. He had received nearly 150 fresh frozen plasmas before and was recently switched on to factor transfusions about a month and a half back. But now he had right arm pain and swelling since 5 to 6 days, and there was family history of a similar disorder in his younger brother. So the clinician suspected the development of an inhibitor and asked us to screen for this. When we did the PT, APTT and the fibrinogen, we found that the APTT was prolonged. So what should we do next? We should see whether it is just a plain deficiency or there is a inhibitor. We do that by doing a mix with normal pool plasma, and we see that the prolonged APTT is still not correcting to within reference range. So this indicates that there is an inhibitor in the patient sample. So once we have this, we need to know what kind of an inhibitor it is, because there are some inhibitors which act immediately. There are some inhibitors which are time dependent. There may be a lupus anticoagulant. Some patients of hemophilia may have associated lupus anticoagulant, and so that question needs to be answered. So for that, we put up an inhibitor screen. In this, what we do, we take the patient's plasma and the normal pool plasma, and we make a mixture of both of them and put all these 3 tubes in a water bath at 37 degrees for 2 hours. After that, at the end of 2 hours, we make a fresh mixture by using this abnormal and the normal pool plasma and do the APTT of all 4 tubes. If the APTT of the immediate mix and the incubated mix corrects, that means there is no deficiency. It's only a factor, there is no inhibitor. It's only a factor deficiency. If, however, the clotting times of both tubes are prolonged, that means there's an inhibitor which is acting immediately and doesn't need incubation to manifest itself. Whereas if the immediate mix shows correction and after incubation the clotting time prolongs, then it's a time-dependent inhibitor. This gives us some clues, because immediate acting inhibitors are heparin, lupus anticoagulant, anti-factor 9 antibodies, and sometimes very strong factor 8 inhibitors can show immediate inhibition, whereas the time-dependent inhibitors are most commonly factor 8 inhibitors. So in this patient, the normal pool plasma was 32 seconds. The patient's plasma was more than 120 seconds. The stat mixture showed a clotting time of 50, and the 2-hour incubation showed a clotting time of 58.8. So what we can say here is that there is a inhibitor, and it gets more accentuated, or the clotting time becomes more prolonged at the end of incubation. So this is a time-dependent inhibitor. So it's most likely to be a inhibitor to factor 8. So what should we do next? We assay the inhibitor by a Bethesda assay. So that gets me to my 6th poll question. A 6-year-old boy with frequent episodes of sore throat and tonsillitis is being taken up for adenotonsillectomy. There's no history of bleeding in the past or in the family, and the surgeon wants us to screen for a bleeding disorder. So he sends a clotting the citrate sample, and what we see is that the APTT is prolonged. When we do a mixing study, we find that there is no correction. So what could be the likely possibility in this patient? Is it a factor 8 deficiency? Is it a factor 9 deficiency? Is it a factor 12 deficiency? Or is there a lupus anticoagulant? Please poll. Yes.
Attendees have answered 4, ma'am. Lupus anticoagulant.
That is absolutely right answer, because we don't even need to look at the other possibilities, because we've already said that if there is no correction, that indicates that it's not a deficiency and there is likely to be an inhibitor. So though the APTT is belonged in all these situations, the fact that there is no correction rules out a deficiency. Okay, so coming to the next poll question, a 1-year-old female with history of recurrent ecchymosis of the skin and an episode of epistaxis was brought for investigation for a bleeding disorder. Her mother gave history of bleeding from the umbilical stump at day 7 after birth, for which fresh frozen plasma was required, and she also received packed red cells. But in the recent past, there was no history of any transfusions. The coagulation screen revealed a normal PT, APTT, and fibrinogen. Which of the following tests would you like to do next? Would you like to do a mixing study on PT or on APTT? Would you like to screen for inhibitors, or would you like to screen for a factor 13 deficiency? Please poll.
All the attendees have answered 4.
So that's quite right. If there is no prolongation of the PT, APTT, what mixing can we do? We are not going to get any correction. And inhibitors, there is no prolongation of the clotting time, so it's unlikely to be an inhibitor. So the only option left for us is a factor 13 deficiency. So how do we do that? We use a urea clot solubility test. This is a screening test for factor 13 deficiency. Now, factor 13 is activated by thrombin, and when it comes into its activated form, all it has to do is convert the fibrin monomer into cross-linked fibrin. This just makes the fibrin more strong, and it binds down the platelets to the endothelium in a more stable fashion so that the clot becomes stable. The urea clot solubility test. So if you understand this, you'll know that factor 13 deficiency will not cause a prolongation in the routine tests of coagulation because the fibrinogen has already converted itself into fibrin. No further clotting is really required. This test is used to screen for severe factor 13 deficiency. So here what we do is we take the plasma. Now we try to clot it with thrombin or calcium. Once the clot is formed, we add urea or acetoacetic acid, which will try and break up the clot and leave the tube undisturbed for 24 hours. If there is enough factor 13 in the sample, the fibrin will get cross-linked and it will form a stable clot. Nothing will happen on the addition of urea or acetoacetic acid. If, however, cross-linking doesn't occur because of a factor 13 deficiency, we won't see a clot after 24 hours of incubation. The advantage, so, is easy to understand. This test is easy to perform in most labs. You just need a test tube, you need a water bath, you need some thrombin and calcium and urea. But the disadvantage is that it takes 24 hours to report. It's not very sensitive because it will not be positive unless the factor 13 levels are less than 5%. And neither is it very specific. If you don't have enough fibrinogen in the sample or the fibrinogen is abnormal, this test will give us an abnormal result. And because it's not so sensitive, we can't use this test to monitor replacement therapy. So in this patient where I have just given you the history, this is what happens. This is in the control tube after 24 hours. I can see the fibrin clot, and in the test sample, the clot has dissolved. So this is a positive urea clot solubility test. We actually need to confirm the factor 13 levels by performing an assay. And this is usually a biochemical assay by amine incorporation or urea release, which none of us usually see because we work in coagulation labs, and this is essentially biochemistry. But we can detect factor 13 deficiency if you look for the factor 13A or B antigen or the tetramer in the A2B2 form. 2 of these and 2 of these. These can be picked up by ELISA or by latex immunoassays on our coagulation analyzers. So we did it by latex immunoassay in this patient, and his factor 13 levels were 1%. So this was a case of factor 13 deficiency. So if the platelet count is normal, yet the patients are bleeding, then we need to screen for a platelet function defect. And this is done by light transmission aggregometry or whole blood aggregometry. Here we take a sample which is rich in platelets. For other clotting factor tests, we need to remove the phospholipids, so we take a platelet poor sample. But here we are looking at the work of the platelet. So we use a platelet rich sample. This is achieved by centrifuging the plasma at low speed. The patient should be fasting because it's a light transmission test. So anything which makes the sample turbid will affect the result of the test. We shouldn't attempt a test for aggregometry if the platelet count is less than 100. The sample is, the platelet-rich plasma is incubated in an aggregometer kept at 37 degrees. Then we add an agonist which will cause platelet aggregation. So that can be collagen, ADP, epinephrine, arachidonic acid. All of these are normally present in our body also, produced by the platelets. If the platelets are functioning well, they will aggregate, and as they aggregate, they tend to start descending into the plasma. So if you shine a light through the sample, the light will be transmitted to the detector. When this happens, gradually over time, a curve will be formed. If there is no curve, then that means there is a defective platelet function, and this is a sample may have a platelet function defect. So I think by now we've covered almost everything, but something is still missing. We haven't looked at how to screen for von Willebrand disease. So remember, we've seen what we would do for the clotting factors. We've seen something for the platelets. We've seen something for the fibrinogen, but we haven't done anything for the von Willebrand factor. And this, surprisingly, von Willebrand factor forms the basis of the most common coagulation disorder. Though many of them don't reach hospitals because they're usually mild. It's a phenotypically very diverse disease with many subtypes, type 1, type 2, type 3, and their further subtypes. And the most challenging part of the von Willebrand disease diagnosis is that the usual coagulation screen may be entirely normal. So if the clinician doesn't suspect a von Willebrand disease, and if your lab is not thinking about it, we may miss this diagnosis completely. So the screening panel for von Willebrand disease, please note, does not have PT, does not have APTT, does not have platelet count, thrombin time, fibrinogen. We need to start screen by looking for the VWF antigen, which can be done by ELISA or latex immunoassay. The function of the von Willebrand factor, is on one side to bind to the platelet. So this we can check by the light transmission aggregometry using platelet plasma and normal platelets in the ristocytin cofactor assay, or we can do it by latex immunoagglutination on coagulation analyzers. On the other side, the von Willebrand factor binds to collagen, and we can check this by the collagen binding assay. This is also a carrier. Von Willebrand factor is a carrier molecule for factor VIII. So if it is defective or decreased, then the factor VIII levels will also fall. So all these 3 tests form the screening panel for von Willebrand disease. So how should we now screen for a bleeding disorder? We should take a good history. We should look at the CBC so that we know that there's a thrombocytopenia or not, and then we run a clotting screen. If the PT or APTT or both are prolonged, then we do a mixing test with the normal pool plasma and with factor deficient plasma. If we get correction with normal pooled plasma and no correction by deficient plasma, we're looking at a factor deficiency. We need to confirm that by a factor assay. If we do not get correction with normal pooled plasma, we're looking at an inhibitor. Then we do an inhibitor screen with incubation. If it is an immediate acting inhibitor, it's likely to be lupus anticoagulant or a factor 9 inhibitor. In that case, we should do lupus anticoagulant testing for lupus anticoagulant and a factor 9 Bethesda assay for factor 9 inhibitor. But if it's time dependent, then it's likely to be factor 8 inhibitor, which we can assay by the Bethesda assay for factor 8. If the PT, APTT are both normal and the fibrinogen is also normal, then we need to exclude von Willebrand disease by doing the von Willebrand screen. We need to exclude factor 13 by doing a deficiency by doing a urea clot solubility test and a factor 13 assay, and platelet function testing by light transmission aggregometry. So this is how I learned coagulation and how we have been practicing. But for all of you hearing that something might change in the future, if there is a patient with a definite history of bleeding and a suspected inherited bleeding disorder, we might not need to even do clotting tests, which are such a problem to perform, and you have to take so much care to perform that. One might just have to take an EDTA sample, send it for NGS, get a genetic diagnosis of which factor is deficient or which factor is has undergone a mutation, or if there is a platelet receptor which has undergone a mutation. And once you know the mutation of a known pathogenic variant, then you can do a relevant assay. If it is a mutation in factor 8, run a factor 8 assay and confirm a factor 8 deficiency or a hemophilia A. If it's a GP1B receptor defect mutation, then you can do light transmission aggregometry or a flow cytometry and confirm a Glanzmann's thrombasthenia. So the exact reverse might be what you see in the future. So this brings me to the last poll question. Which of the following is not a screening test for a bleeding disorder? Prothrombin time, activated partial thromboplastin time, platelet count, or a factor assay? Please poll. Yes?
All the attendees have answered 4, option 4.
Absolutely right. So the factor assay is not a screening test. The screening tests are the first 3. So I'd like to conclude this talk today by saying that screening tests are helpful in detecting an abnormality in the clotting mechanism, and abnormal screening tests would indicate a deficiency of a clotting factor or the presence of an inhibitor. A stepwise approach is recommended in testing to avoid wastage of precious patient plasma and expensive reagents and to save time. And the results of the screening test depend on the nature of the reagents we are using. So we must match our reagent with the kind of indication that we are working up in a patient. And all screening tests must be followed by confirmatory factor assays or other tests to reach at the correct diagnosis. Learning is always teamwork, and I'm very, very grateful to the staff at the coagulation lab in PGI, who over the years have taught me so much in the coagulation test through my mistakes, through their mistakes. We've all learned together. And our clinical colleagues who keep sending us these wonderful cases, which teach us so much about coagulation, and the DM residents who take history and follow up cases and keep asking us questions which force us to think. So that brings me to the end of my talk. Now I would hand over the podium to Dr. Naveen Kakkar. I'm sure he has so much experience in coagulation. He'll have some very nice cases to discuss with us. So over to you, Dr. Naveen.
Thank you, Dr. Jasmeena. Thank you, Dr. Jasmeena, for a wonderful, wonderful session, making this complicated topic simplified for everybody. And I don't have much to say after this, but 2 cases that I just want to run through to emphasize some points. Let's go to the share screen. Please confirm if you can see my screen.
Yes, we can, but yes.
Okay, right. So lots of trains in this picture, very complicated railway. There are 29 trains here, and these 13 factors make us go like merry-go-round every day. So as Dr. Jasmeena said, it's a problematic area and not very difficult to sort out in the lab. But if you have a stepwise approach and it takes time to get this experience in this part. So just for the audience, there are 5 most common causes of coagulation issues that you face in the labs, and they'll come one by one, and it is the sample, the sample, the sample, the sample, the sample. Dr. Jasmeena emphasized that in the first part of the talk, that you have the pre-analytical variables play such a major role that your test can go totally wrong if your sample is not taken, transported, or stored well. So please, a request to all of you, if you have clinical friends in the clinical colleagues and friends, please inform them. Your sample quality is the key. You're starting off before the interpretation of this complex with the testing with very expensive reagents and sometimes problematic testing requiring repeats. Lots of repeat sampling is required at times. Just 2 cases. Case 1, I've done that in a previous talk somewhere. So some of you have seen this earlier. Just a repeat, but it doesn't matter. So it's a 72-year-old male who came with the history of total knee replacement done in an outside hospital, and we were given a consult for the cause of bleeding. And what happened was there was bleeding from the surgery site. The surgeon explored. There was only a generalized dose, but they achieved hemostasis. Nothing else was done. CT angiogram showed no aneurysms, no leaky vessels. But he bled twice again, requiring re-explanation. Not a good thing in a 72-year-old to be explored twice after what seemed like a routine TKR. Now the lab test showed a prothrombin time of 11.2, an APTT which was prolonged about 10-12 seconds beyond the control value. Factor assay was sent to the laboratory. This is before the test came to us. Factor 8 was 35.9%, factor 11 was 9.1. As a rule of general thumb, if you look at 50 to 150% is a normal factor levels for most of these. So both are low here. The patient was infused factor 8 twice, but there was no response. It kept on oozing. There was no action taken on the low factor 9, which was actually lower than 8 because of the poor availability of factor 9, and the plasma was not given. However, we know still that the patient has not responded. The repeat factor assays done with us showed a factor 9 of 22.4 and a factor 8, which is normal, on the higher side, in fact. So that's a picture where the moon is almost as bright as the sun. So if you see 2 factors down, it should ring an alarm, because unless you're dealing with an acquired cause like DIC or vitamin K deficiency, the inherited pathway factors being with a normal PT, APTT prolonged because of 2 factors is very, very unlikely, very, very rare. So the lesson learned from this case actually was this sample was sent to Delhi from Ludhiana, so transported. So it was actually a pre-analytical variable. The activity of both factors was lost. The loss was more in 9 than 8, and hence the wrong diagnosis. So actually he had what he had, if you go back here, he actually had a mild factor 9 deficiency and bled because of that. He required either a factor 9 concentrate or an FFP. 8 was not required. So pre-analytical variables is very, very important. Off-site testing can be very tricky. It's good if you have the patient with you and you have control over the sensitivity to temperature and storage conditions. Second case is kind of unique to India. I'm writing a small correspondence on this. I'm not sure if that will get accepted, but we see these pictures in India mostly. This is actually Bangladesh, but India is no different. And this one again, down south. Now the case 2, our technologists reported to the pathologist about prolonged PT, APTTs, both more than 2 minutes, not in one case. It was happening more than usual, 2-3 cases in that day. Normal reports were also seen in between. The clinical history of all these patients showed no history or no reason for such prolonged results. All the reagents were changed. The results were still prolonged. Manual tests were normal in all these patients. We had about 7 patients that day, 2 the next day, where manual testing was normal. Only the semi-automated analyzer results were prolonged. Just a plot, nothing great, but 2 minutes on the manual count and normal values, that's for PT. And the other one for APTT. Again, the 2 minutes is fixed for the automated values, the manual count and normal values. The problem we found out later, about 3 days later, when we use the cuvette for a semi-automated analyzer, they give you these stirrers, the magnetic stirrers, and these are actually, they rotate and mix the reagent while the testing is being done. So what we found out was that the company supplying these, they had the cuvettes, but they ran out of the packet of stirrers. What they did was, from the local Ludhiana market, they got somebody to have these wires cut and made stirrers, makeshift stirrers, thinking they won't matter. But the ion content for the magnet was poor. So what actually happened was we were supplied faulty stirrers, and I went to the biomedical section and took a big magnet, and the correct stirrers were actually adhering to the magnet, sticking to, and the other stirrers were just moving, wobbling, or not sticking. So what was happening, there was a mix of good and bad, and that is why some tests were normal, and these tests were actually because the instrument senses the rotating time, so it was not reaching the endpoint at all. It was going to the maximum, which is 120 seconds. So that is why we had a prolongation. So this is again a problem with the analysis, and the point I want to highlight is India is India, expect anything. This was a jugaad which did not work. So just organizers for inviting and Dr. Subha.
I'm not able to see any questions in the chat box or question answer sections, ma'am.
Should I take that as a good sign?
Yes, definitely.
And you got all your poor questions were answered.
Rightly by most. No questions, ma'am?
Yes, and any final comments from the chairperson or the presenter? Yeah.
Yes, ma'am. In the chat, everybody is liking this, liking your presentation, saying excellent presentations, ma'am.
Thank you very much. I'd just like to say that I used to dread the coagulation testing a lot as an MD student because the exposure to coagulation was very poor. But and when I was posted to the coagulation lab, I used to think that this is a punishment. There's no fun of seeing morphology and those lovely cells and deciding whether this is a carcinoma or XYZ. But I think the charm of coagulation is you're absolutely tied to the patient. You need to know what is going on there. Has he received a transfusion? What kind of a sample have you collected? You have to think like a physician all over again. So that is what really kept me going in this side. And I think quality control is a very, very important part of coagulation testing more than any other thing in the hematology lab, I would say. So if you plan to set up a coagulation lab or work in a coagulation lab, make no compromises on that.
There is one
Very
question
much for your
popped
attention
up.
today.
Okay, ma'am, excuse me, ma'am. There's one question popped up. What is the 2-stage assay of factor 8?
So I have to confess that I have never really gone into this 2-stage assay, because I used to find this very cumbersome, and things are now much easier in the 1-stage assay, which is, you just see how much of the patient's plasma will correct the clotting time of a factor 8 deficient plasma. The 2-stage assay, however, is now modified to use a chromogenic assay, wherein we will develop, 2 parts of the reaction will lead to the formation of 10A, and the eventual conversion of a colored compound, non-colored substrate into a colored compound will be carried out by factor 10 rather than factor 8. The exact thing in the 2-stage assay, I don't remember myself. I'd be very happy if Naveen recalls anything, how it's done. I've never seen it done or ever used it really in my own lab. Thank you for asking that tricky question. I'll have to sit and read it now.
One more request has come. Can you repeat a case of boy with prolonged isolated APTT?
So should I go back to my presentation?
Yes, ma'am. Yes, please.
Okay. Oh, I've lost my presentation now.
One more question is there, ma'am. Importance of a aged sample and adsorbed sample.
Yes. So aged plasma and adsorbed plasma can also be used to perform mixing studies, because aged plasma aged plasma or serum will be deficient in the labile factors, that is factor 5 and factor 8. So if you have an APTT prolongation and you want to see if it's a factor 8 deficiency, it will not correct with aged plasma. Adsorbed plasma will remove the vitamin K dependent factors, so it will help us to answer the question. If there is a prolonged APTT which is showing correction with aged plasma but not with adsorbed plasma, then it's likely to be a factor 9 deficiency. And this can be made easily in the lab. But the problem with adsorbed plasma is that it has to be standardized very well, that the prothrombin time has to be of a suitable length before you can use it. Otherwise, you may not get the correct answer. The factor deficient plasmas, the technique which I discussed, is a more expensive exercise, but it seems to give us much more clearer answers, so we tend to use it. In fact, some people say don't even do the corrections with different deficient plasmas, go straight to factor assays. It saves time in the long run, but it becomes an expensive exercise.
One more question. What should be the time difference between last transfusion and factor testing?
So there is, if we think on what we are trying to look at, is that we want whatever was transfused into the patient should be less than 1%, so that there is no effect of that transfused factor in the circulation. But we know that all clotting factors have different half-lives. Some of them are very short half-lives, say for instance factor 7. Others are very long half-lives, say for instance factor 13. By the time 5 half-lives are over, the amount of factor which you had initially transfused, suppose it's 100, it will now be less than 2.5%. Each time one half is decreasing. So from 100 to 50 in the first half-life, then to 25 in the second half-life, then 12.5 in the third half-life, and so on. So you would like the transfused factor to come down to bare minimum. So allow at least 5 half-lives to go before you do a test. Now, but when you get a fresh case, you don't know what deficiency does he have. Does he have a factor 8 deficiency? Should I wait for 5 half-lives of factor 8? Should I wait for 5 half-lives of factor 7 or 9? So that becomes the real challenge. Most of us in labs, we tend to wait for 7 to 10 days after a last transfusion before testing. But remember, these days there are some pegylated products or some factors which have long half-lives, and soon this will not be a good way to exclude the kind of the effect of transfused factors. So we need to make sure that at least 5 half-lives have elapsed to get the baseline level of the individual and get the correct prolongation and factor assay level at that. I don't know if I made myself clear.
One more question. What should be done for borderline APTT levels? Example, 40 seconds with control and of 30 seconds. The anesthetists are worried about such readings. What should be done?
So most important is the history of bleeding. It's not the test that we should be chasing, it should be the history. And many times I think the history is far less taken in a far less diligent fashion as compared to the test. So if there is no history of bleeding, and we are very sure that there is no previous history of bleeding, there is no family history of bleeding, and the clotting time is just marginally prolonged, I don't think there is any reason to worry. Sometimes it may be, especially for an APTT, it may be because of a lupus anticoagulant. Now, lupus anticoagulant will cause thrombosis rather than bleeding in the patient. So it will not make any difference. But of course, your clinical counterparts, and they will always be anxious about this, and they might say that it may be this factor deficiency, it may be that factor deficiency. You may have to do a workup to prove your point, but many times it will not yield anything. A history is always very, very helpful. Of course, we can always argue it out that if there is a mild factor deficiency, maybe we won't get a good history at all. In that circumstance, yes, if we are worried about that, we will have to work up the sample. This is easier said than done. I face the same pressure all the time. What about you, Dr. Naveen? How do you tackle those borderline prolongations?
Yeah, I think you mentioned it right. It's a clinical correlation. What is happening to the patient is most important. However, having said that, we've had to do factor assays and even mixing studies sometimes to sort these out for the clinicians who are anxious. And Dr. Jasmina, can I ask you one question to clarify for the rest of the audience? The status of bleeding time, because a Mayo paper 2008 said it is not a predictor for intra bleeding, and neither does a normal bleeding time predict that patient will not bleed, or the opposite. Because a Mayo paper 2008 said it is not a predictor for intra bleeding, and neither does a normal bleeding time predict that patient will not bleed, or the opposite. So it has no role unless in a platelet function disorder that you're looking for. So what's the practice? Because lots of anesthetists and surgeons in many hospitals still vouch for a BT-CT pre-op. So can you please clarify for the audience on that?
So I hope Dr. Sukesh Nair is not listening to this talk, but they put up a very good paper recently where he has sort of tackled this thing head on. If we are randomly looking for a bleeding disorder, then BT-CT is not going to help. BT will not help. It will not be sensitive enough. And a CT is also not sensitive. It's better to do an APTT if we are, thinking we are actually hunting for a bleeding, if you're screening preoperatively. But if there is a history of a bleeding disorder and you don't have the platelet aggregometer, or you don't have the von Willebrand factor antigen assay available to you at a primary level hospital, if you can do a good bleeding time, if you have a skilled operator who is well versed in it, then this might give you a clue that there is a bleeding defect there which needs to be further worked up. It's only a screening test. So that's all the information it is going to give me, that there may be a platelet function disorder, or there may be a vessel disorder which needs to be further worked up. But randomly just doing it, the way we, I have to admit, we also used to see it in our MBBS days, that just do BT-CT and screen for do it as a preoperative screen. So we'll hardly find any abnormal tests because how common are our bleeding disorders? Not very common at all. The only situation where I think BT still is holding ground is in a kidney biopsy. That there it is still recommended that a bleeding time should be done prior to carrying out a kidney biopsy. Otherwise, I'm
Thank
not
you.
aware of any other situation, in a preoperative setting or a pre-procedure setting where a bleeding time will help. We don't do it at all. Very heroically, when I just joined the lab, I started trying it on patients, but it was quite neither of us were good in it, nor were the we were left with very disgruntled and unhappy patients, and it was only a screening test. So if we have a platelet aggregation screening test, at least some part we could do with that. And now with flow cytometry available in some settings, the easier to diagnose platelet function defects we can catch that way. Of course, the secretion defects we won't get, and there may be other certain platelet function defects which we won't get by that. So there are limitations, but this test is not to be thrown totally into the dustbin. If you have nothing else and it's abnormal, you can think of working up further. But don't go hunting around in normal patients whom you want to take up for surgery.
Thank you, ma'am. Thank you so much. Dr. Shubha, Dr. Lupa, any more questions from the audience?
No, no, sir. There is no more questions.
Okay, thank you, Dr.